السلام عليكم ورحمة الله. كيفكم يا شباب؟ كل عام وانتم بخير. Today we are going to speak inshallah about malnutrition. Firstly, as introduction, brief introduction, nutrition is a term, تغذية. What we mean by nutrition is a process to utilize the food to our body. Why? To maintain life, to maintain growth, to maintain health, to maintain working in the life. So this is nutrition. This is the meaning of nutrition. عكسها, in opposite is a malnutrition. It is any form of disordered nutrition. يعني سوء التغذية. Disordered nutrition. And this malnutrition or disordered nutrition includes both end of nutrition spectrum from undernutrition to overweight. يعني even the obesity and overweight is a form of malnutrition. We mean malnutrition includes a spectrum of undernutrition, underweight, to the other side, overweight or obesity. Undernutrition is usually an outcome of three factors: household food supply. We mean by that poverty mainly, يعني الإمداد التغذوي. Second, child caring practice, يعني we mean family practice, mother practice. And the third is access to the health, water, sanitation services. So these three main factors contribute to the form undernutrition or malnutrition. Regarding the etiology of malnutrition, we have many causes, but here we are going to speak about the more important etiology. Number one, we have malpractice regarding breastfeeding and weaning, الفطام والرضاعة. These important, very important causes. Example, lack of exclusive breastfeeding. We mean by this is early weaning, that the mother decides to wean her child since the age of 1 month, 2 months, 3 months, or even since birth. الفطام. Weaning is الفطام. The important point here, the introduction of any type of food except milk, breast milk, this is weaning. يعني حتى الموية اللي بيدوها للبيبي since birth, this is weaning. This is malpractice. Definitely will affect the nutrition of this child. So lack of exclusive breastfeeding is an important risk factor. As we know, breastfeeding should be exclusively for at least 6 months. Okay. Second example is prolonged exclusive breastfeeding. This is opposite of the last point. تقوم الأم تعمل prolonged breastfeeding up to 3 years, 4 years without adequate introduction of the food. يعني تقوم بترضع 2-3 سنة without introduction of sufficient food. Third example is sudden traumatic weaning, that the mother suddenly decide to wean her child suddenly. فجأة يقرروا إنه to wean this child، يسوقوا يودوا له حبوبة في قرية تاني في بلد تاني، or even in the same house، لكن never يكون beside her mother or beside the mother of the children. Okay. Then next point is inadequate complementary feeding practice. Okay, in this point we mean that the mother complete the breastfeeding period, which is 6 months, and when she start to wean her child at the age of 6 months by giving food, this process is called complementary feeding. So complementary feeding should start at the age of 6 months, as we know. But at this point, the mother gives her child very bad quality or poor quantity of the food to her child. تديه أكل ما نافع, literally. Okay, what we mean by poor quantity and poor quality? تديه بسيط أو تديه نوعية ما كويسة. مثلا mainly the mother concentrate on carbohydrates or juice or protein or any type of nutrition. Example, تديه مثلا mainly carbohydrate, تديه بسكويت بس. تكون كل 6 شهور second 6 months of life من تبدأ خلاص تدخل الكومبلمنتري فيدنج، تقوم تدي كربوهيدرات، تدي بسكويت، تدي مثلا زبادي بس، تدي شعيرية، تدي عصير، تدي مازة. they love مازة so much. The third point is the family factor. We mean by family factor is large family size, no spacing between children, so that this will lead to early weaning. لأنه حتكون each year this mother is pregnant, so there is early weaning for the children. Then maternal factor. The important factor regarding maternal factor is ignorance of the mother. جهل المother، جهل الأم، جهل المother about the best food, the best quality, the best quantity, or death for the mother, death of the mother, or separation, divorce, or mother illnesses, or this factor will affect the nutrition of the children. Then we have starvation. Starvation mainly due to poverty, due to unavailability, or taboos. Taboos mean wrong belief، اعتقادات غذائية خاطئة. عندنا a lot of taboos in Sudan. Example, the egg will delay the speech. عندهم كده. They believe that if the child receives egg at 1 year, this will affect the speech. Other taboos, the lemon juice or the orange juice will lead to vitiligo or will lead to lung problems. So this is taboos، عادات غذائية or belief، معتقدات غذائية خاطئة due to religious, due to customs, due to many so factors. Lastly, we have the most important etiology for malnutrition is repeated infection or severe childhood infection, mainly diarrheal disease or tuberculosis or HIV. This is main infections risky for malnutrition. Then we have undernutrition. The greatest risk time to develop undernutrition occur in the first 1000 days of life. أول 1000 يوم من الحياة. This is أول 1000 يوم من الحياة started from conception to 2 years of age. لو عديناها هنلقاها 1000 days of life. أي trauma، أي event، أي nutritional problem, even in pregnancy, even in delivery, post-delivery, during the first 2 years of life, this will affect nutrition and even life of the child. Example, if the mother has folate deficiency, we mean if the mother has folic acid deficiency, the baby for this mother will develop neural tube defect. This will affect the nutrition, it will affect the life, it will affect the quality of the life for this child. Again, example, if the mother has iron deficiency anemia in pregnancy, so her child will develop iron deficiency anemia, and this child will develop iron deficiency anemia in the first months of his life, and etc. So, the first 1000 days of life, this is the greatest time to develop undernutrition. يعني لو خلاص this child passed these 2 years from conception up to 2 years, any nutrition or any malpractice occurring after 2 years will be less to affect nutrition for this child. Then we have important point that is undernutrition is not confined to low income countries. It can occur in high income countries, mainly in chronically ill patient, ICU patient, and chronic disease patient. Example, HIV, tuberculosis, cystic fibrosis, and etc. So we mean that chronic ill patient, ICU bedridden patient, these patients risky for undernutrition even in high income countries. Okay, regarding the anthropometry, we have firstly height for age, الطول للعمر, and we have length for age if the patient is less than 2 years. So, patient less than 2 years, length, patient more than 2 years, height. Is the measures of linear growth. Okay. Any deficit or adverse event occurring in the first 1000 days, as we mentioned previously, this results in stunting or chronic malnutrition. Stunting is التقزم الغذائي. Okay. A low height for age, يعني كلهم يكون قصار. For any country, this reflect low socioeconomic status for this country. يعني لو لقينا كل الحتة المعينة دي ناس متقدمين قصار شديد معناها they have a low socioeconomic status. Okay. Then we have weight for age اللي هو up to الوزن للعمر. is commonly used index for nutritional assessment in pediatrics because it is easier to measure, as we know. Then what is the limit to use weight for age? It has a disadvantage. What is this disadvantage? It doesn't differentiate between wasting and stunting. What is the meaning of that? يعني طفل عمره 5 سنوات وزنته لقيت وزنه ضعيف. هل وزنه ضعيف لأنه stunting لأنه متقزم ولا وزنه ضعيف لأنه wasting اللي هو هزيل ضعيف؟ So weight for age, it doesn't differentiate between stunting and wasting. This is the limit to use weight for age. Okay, we have what is called weight for height, الوزن للطول. So يعني هنا بدل ما نشوف الوزن للعمر المعين لا نشوف الوزن للطول ونقارنه بالستاندرد ديفيشن بس ده سكور in WHO gross chart. A low weight for height or wasting. So wasting is the low weight for height. Usually indicate acute malnutrition. And high weight for height usually indicate overweight or even obesity. So weight for height is not weight for age. يا شباب لازم نفرق بين حاجة دي. لأنه weight for age it doesn't reflect in wasting, but weight for height, a low weight for height معناها wasting. So عندنا في الصورة زي ما ظاهر عندكم first child is normal, secondly is wasted هزيل ضعيف, third one is stunted متقزم غذائيا متقزم, and the fourth is wasted and stunting. Thirdly we have antagonistic called MUAC اللي هو نحن نقول عليها مواك. MUAC stand for mid upper arm circumference, usually done in the left arms from the tip of the shoulder to the tip of the elbow, midway between 2 points, between 2 bony prominence, olecranon bone and acromion bones, the midway between these 2 bones. بعدين بنلف الشريط الظاهر عندكم في الصورة ده اسمه شاكر تيب, فيه green area فيه yellow area and red area. Red is red يعني معناها alarm, yellow is in between the green and yellow, yellow is in between the green and red, and green is normal. Okay. بمعنى ثاني green is normal or mild wasting, yellow is moderate wasting, red is severe wasting. So what's severe? MUAC is any mid upper arm circumference less than 11.5 centimeter. Any MUAC less than 11.5 centimeter, this is severe wasting equivalent to low weight for height. Fourthly, we have BMI, اللي هي stands for body mass index. Usually it's less commonly to use. BMI less than -2 standard deviation in gross chart, in WHO gross chart indicate thinnings. Regarding the classification of undernutrition, we have so many classifications. The most important we are going to speak about is Gomez, is Wellcome Trust, Waterloo, and WHO. Regarding Gomez classification, mainly depend on the weight, standard weight. It's not used in hospital, is used mainly for researches. Gomez from 90 to 75th reduction of median weight for age, this is mild or grade 1. 75 to 60%, this is moderate or grade 2. Less than 60% reduction of median weight for age, this is severe or grade 3. Second, we have Wellcome Trust classification. This developed in 1969. Regarding Wellcome Trust, either edema or no edema. So Wellcome divides his classification to two main division, with edema or without edema. Reduction in weight from 80% to 60% with edema, this is called kwashiorkor. Reduction in the weight from 80% to 60% with no edema, this is undernutrition or underweight. Again, reduction in the weight to less than 60% with edema, this is called marasmic kwash. And reduction in the weight to the less than 60% without edema, this is marasmus. This is the very famous classification. وزي ما قلنا زمان احنا درسنا kwashiorkor and marasmus, the very famous term, but now is completely obsolete. Third classification is Waterloo classification. It developed in 1972. Waterloo is classification include wasting and stunting, الهزال والتقزم. Waterloo classification regarding wasting, 90% to 80% of median weight for height, this is mild. Less than 70% is severe. This is regarding wasting. أما stunting, 95 to 90% of median height for age is mild. 90 to 85% is moderate. Less than 85% is severe stunting. Then we have WHO classification of undernutrition, and this is what is used now. حاليا in the hospital we use this WHO classification, and it is the most important one. But you have to know that there is what is called Gomez classification, there is what is called Wellcome classification, and there is what is called Waterloo classification. The most important one is WHO classification of undernutrition. It include again wasting and stunting. Wasting classification by weight for height and by MWAC. يعني ناس WHO صنفوا لنا الويستنج اللي هو الطفل الهزيل يا إما بوزنه لطوله ولا بالمواك. طيب نمسك WHO when they use weight for height. Less than -2 Z-score, or less than -2 to more than -3 standard deviation weight for height, this is moderate wasting. Less than -3 standard deviation or less than -3 Z-score weight for height, this is severe wasting. This classification by WHO, you have to know it very, very, very thoroughly. Regarding stunting, regarding التقزم، ناس WHO صنفوا كيف؟ any less than any height for age less than -2 to more than -3 standard deviation, this is moderate stunting. Less than -3 standard deviation height for age, this is severe stunting. ده التقزم، اتصنف هكذا. Regarding wasting by using MWAC, from 115 to 125 millimeter MWAC, this is moderate. Less than 115 millimeter, this is severe wasting. ننتبه لأنه المواك ممكن يكون بالمليمتر، ممكن يكون بالسنتيمتر. لما يكون بالمليمتر بنقول 115 millimeter, less than 115 millimeter is severe wasting, or less than 11.5 centimeter is severe wasting. طيب يا شباب، من هنا هنخش لحاجة اسمها SAM. SAM is a very famous term in pediatric. You have to know it in and out. SAM is stand for S, severe, A, acute, M, malnutrition. Severe acute malnutrition is SAM, defined as severe wasting and or bilateral edema. يعني لما نقول severe wasting يا شباب خلاص بقت في راسكم wait for height less than minus 3 standard deviation, or لو استخدمنا المواق less than 11.5 centimeter. This severe wasting. So severe wasting is extreme thinnings diagnosed by weight for height or weight for length if the patient is less than 2 years. By WHO gross chart يكون less than minus 3 standard deviation. أتمنى أن يكون الحكي دي واضحة شديد. Regarding the children age 6 to 59 months, أمواج less than 150 mm also define wasting. Important point here, أمواج used for children more than 6 months is not used for children less than 6 months. Why? Because if you use MUAT in patient less than 6 months, definitely you will find it less than 11.5, and you are going to classify this child as severe wasting, and the patient is not severe wasted, but this patient is small for his age. لسه ما كبر يعني. Regarding bilateral edema is a clinical sign by grasping both feet for a minimum 10 seconds. بعدين we are placing a thumb on top of each. هيحصل gently, أهم حاجة يكون gently for a minimum 10 seconds. This is TAM. So what is TAM? Severe wasting and or bilateral edema. Okay. TAM definition of TAM distinguish wasted or edematous children from those who are stunted. ليه نحن عملنا TAM؟ ليه ناس WHO قالوا لا نحن نعمل حاجة اسمها Severe Acute Malnutrition ونعرفها بالتعريفين اللي قلناهم دين. To differentiate يا شباب between wasted child and edematous child from those who are stunted. As stunting children is not a priority or is not indication for admission. يعني الطفل المتقدم غذائيا أنا ما حأسوق وأدخله المستشفى لحد ما يطول. So is not a priority for acute clinical care as their deficit in height and weight cannot be corrected shortly. So WHO make TAM as separate term including wasted and edematous children, which is different from stunted children. Previous name زمان كنا بنقول BEM اللي هو protein inert malnutrition, now is avoided completely. And again marasmus squash is welcome classification, again is obsolete now, but in study purposes still we are learn student by marasmus squash, but in hospital ground it doesn't use. Okay شباب, regarding the clinical manifestation of SAM, we have two parts, severe wasting and edematous child. Severe wasted child, the first important sign is severe wasting. We mean wasting. We have a special area, you have to check wasting on it. So most visible in the inner thigh, in the buttock, behind, in the upper arm, in axilla we mean, ribs anterior and posterior and subscapular. So even in your clinical examination, please, in your clinical examination, when you are asked to examine for wasting, you have to search for wasting in this area. Again, inner thigh, buttock, ribs anterior and posterior, axilla and subscapula. Regarding the face, relatively at the beginning of the story, the face will return normal, but eventually it will become very wasted, leading to old man appearance. Regarding eye, it will be sunken eyes from retroorbital fat losses, and abdomen will be distended from the gas due to bacterial overgrowth. So the shape of the patient will be old man faces with sunken eyes, with distended abdomen, with very irritable child, severe wasted child, عندهم very specific mood which is irritable بدون ما تهبشوا بيبقوا very irritable child. The age commonly this severe wasting occur in infancy. In infancy we mean less than 1 year and very young children. عندكم صورة هنا في المحاضرة هتلقوا فيها the same signs we mentioned. Regarding the edematous malnutrition, edema is most likely to appear firstly in the feet and then progress to the lower limb, and it can be developed to generalized edema. Skin changes mainly occur in edematous malnutrition over the swollen limb. This is called flaky-pain dermatosis. هنلقى صورة برضو في المحاضرة. The hair is sparse, easy bald, easy pickable, pale, and hair may be reddish evenly. Regarding the liver, in edematous malnutrition, it will be fatty liver. So hepatomegaly is due to fatty liver in edematous malnutrition. The main precipitating factor is weaning factor, sudden weaning factor, early weaning. This is all risk factor for edematous malnutrition. Protein deficiency, again, infection. So this is main precipitating factor for edematous malnutrition. The mood for this edematous child is miserable, apathetic, ما شغل بيك الشغلة. الداك كان severe wasting بيكون very irritable. أما ده هنا miserable and apathetic child. We have bad sign regarding this edematous malnutrition: ascites, purpura, jaundice, huge liver. This is all bad prognostic sign in edematous malnutrition. Regarding the age, is commonly age of weaning, 1 to 3 years. It's not age of infancy as in wasting malnutrition. And this is picture reflecting what we are saying. And this is flaky-pain dermatosis. Okay, شباب, regarding pathophysiology of malnutrition, we have reductive adaptation. It is very important term. You have to know it. It is occur when there is an insufficient intake of feed to meet daily need for this body. This is result in changes occur in sequence. Changes occur metabolically and physiologically. These changes why occurring? بتحدث هذه التغيرات عشان to conserve energy for life, to prolong life and to conserve energy. يعني كل التغيرات في الميتابوليزم والتغيرات الفسيولوجية في الجسم عشان تحفظ كل طاقة الجسم to conserve energy to prolong life. By mean example, fat store are mobilized to provide energy. يعني بدل الفات ما يحصل لها storing، لا، كلها بيحصل لها mobilization to energy production. Protein in the muscle, in the skin, in GI tract is also mobilized. So these changes, it is called reductive adaptation. Energy is conserved by reducing physical activity and growth, reducing basal metabolism and functional reserve of organ, and by reducing inflammatory and immune responses. All these metabolism, all these physiological action, it will be reduced. Okay. Next, these changes have important consequences. Then, due to these changes, what is the result in the body? Okay. Firstly, لو مسكنا الليفر, glucose less readily, making the child more prone to hypoglycemia. So this liver it not act well. Albumin less produced, transferrin is also produced by liver, is less produced. So the liver cannot handle every toxin in the body. Regarding heat production is less, making this patient more prone to hypothermia. Regarding the kidney, less able to secrete sodium and fluid, so there is a liability of fluid overload. Regarding sodium buildup in the body, it will be more. So any patient with malnutrition have an excess sodium. So زي ما عارفين الصوديوم بيجر معاه الموية leading to excess body sodium, fluid retention and edema. Regarding potassium leak out from the cell and excreted in the urine. So any patient with malnutrition has hypokalemia and high sodium. This is very important when you are investigating this patient and when you are treating this patient. This hypokalemia will lead to anorexia and signs and other signs of hypokalemia. Regarding heart, is weaker and weaker to pump, so reduce cardiac output and the patient more liable to develop heart failure. Regarding the muscle protein, is loss of muscle protein is accompanied by loss of potassium, magnesium, zinc and copper. Regarding the GIT, there is colonization of bacteria all over the GIT system. Cell replication and repair are reduced, increasing the risk of bacterial translocation through the gut. So there is colonization of bacteria in the stomach and small intestine, and there is bacterial translocation crossing these gut mucosa. Regarding immune system, what is changes occur? There is impaired cell immunity. Cell-mediated immunity, it is impaired. This results in increasing risk of undiagnosed infection. So this patient might have very severe infection and have no signs of this infection. So this important point, when you're dealing with a patient of malnutrition, you have to suspect infection because this patient will not develop usual signs of infection. Regarding red cell mass, it will be reduced, releasing ion which require glucose and amino acid to convert to ferritin. This more and more leading to risk of hypoglycemia and formation of free radicals. Regarding micronutrient deficiency, limits the body ability to deactivate free radical which cause cell damage. These all changes occur in the body because of less intake of sufficient feed. الحاجات التغيرات اللي حصلت دي كلها اسمها reductive adaptation. Okay, regarding examination of child with malnutrition, we have 5 main points in examination of malnourished child, starting from general examination as usual, plus mood. You have to comment about the mood with 5 D's as usual. What is 5 D's? Is patient disease, well, ill, very ill, dysmorphism, distress or not, dimension of the patient and any detachment, example, IV, line, NG tube. And you have to comment as we say about the mood. يعني قلنا لو كان wasting child هيكون very irritable, لو كان edematous child هيكون apathetic, depressed child. So you have to comment about the mood. Second, we have vital signs, pulse rate, blood pressure, capillary refill time, respiratory rate, temperature. Please offer to do random blood glucose because as we say, these patients are more liable to develop hypoglycemia. Thirdly, we have signs of malnutrition, specifically 4 main signs of malnutrition. Wasting, وقلنا وين الحتات اللي انت you have to check for wasting. Second, dermatosis in the lower limb, you have to search thoroughly. While you search for dermatosis, please don't forget anal excoriation. Third sign of malnutrition is lower limb edema, and fourth is hair signs. The fourth point regarding examination of malnutrition, anthropometry. As we say, anthropometry include weight, height, head circumference and MUAC. Lastly, you have examination. You have to examine the child from head to toe. طيب عندكم الجدول ده يا جماعة في المحاضرة في lectures. Please read it carefully. From head to toe, you have to comment about face, eyes, mouth, teeth, hair, skin, nails, skeletal deformity, abdomen. You have to check for cardiovascular precordium, you have to listen for precordium, you have to auscultate for the chest, you have to do brief neurological examination, hematological, and as I say, you have to comment about the behavior and the mood. Okay, regarding management of patient of malnutrition, you have 4 main points in management as we know. Firstly, you have to take detailed history targeting the risk factor. لازم تطلع من الهيستوري بالريسك فاكتور for these patient. الريسك فاكتور هي الاتيولوجي اللي قلناها في البداية. اوكي، يعني السبب شنو اللي خلى these patient to develop malnutrition. اوكي، this is number 1. Number 2, you have to do thorough physical examination as we know, and as I said in examination of malnutrition عندنا 5 حاجات مهمات بس قلناها لازم تعملها. نمرة 3, you have to investigate the patient. Firstly, the first important investigation, you have to do random blood glucose because this patient is very risky to develop hypoglycemia. Why? لأنه عرفنا في تغيرات بتحصل وشرحناها in form of reductive adaptation. Secondly, you have to check for peripheral blood film for malaria, CBC, ESR, urine examination, stool examination, renal function and liver function test, and X-ray regarding deformity, and chest X-ray searching for consolidation, for cavitation, for any signs of infection. If the patient is not responding to treatment, you have to suspect tuberculosis, you have to check for acid-fast bacilli, sputum for acid-fast bacilli, you have to consider HIV. This is investigation. Lastly, treatment. Regarding treatment, we have stabilization, transition and rehabilitation, social and psychological support, as we are going to see coming. السلايد الجاي دي يا شباب مهمة شديد. Update on admission criteria. We have update اللي هو أنا جبت لكم هنا في المحاضرة. This is admission criteria. تحفظوها عن ظهر قلب. What are indication for admission? Criteria for admission. Severe edema اللي هي grade 3. يعني grade 1 edema is not indication for admission. Grade 2 edema is not indication for admission. Severe edema اللي هي grade 3 or severe wasting. severe wasting عرفناها هي شنو، عرفناها في البداية قلنا هي weight for height less than -3 Z score less than -3 Z score، شرحنا Z score or مواك less than 115 ملم. severe edema or severe wasting. براهم؟ لا ما براهم. معاهم شنو؟ with. So I highlight it with red in the slide. with medical complication. I mean severe edema grade 1 or grade 2. Severe wasting without medical complication is not indication for hospital admission. With medical complication. What are these medical complications? Next slide. They are anorexia, poor appetite, vomiting, intractable, convulsion, lethargy, not alert, unconsciousness, hypoglycemia, high-grade fever, hypothermia, severe dehydration, persistent diarrhea, lower respiratory tract infection, severe anemia, eye signs of vitamin A deficiency, and skin lesion. These are medical complications regarding SAM, severe acute malnutrition. So what are the admission criteria? Severe wasting or edema with medical complication. Okay, children with severe acute malnutrition are often seriously ill. ربعهم have anorexia and severe infection. 25% of these patients have anorexia and severe infection. We need admission until patient is stable, and usually stabilization period take from 2 to 7 days. We have what is called appetite test. يعني شنو؟ Appetite test mean the patient able to eat 1/3 of RUTF. In the coming slide, we are going to know what is RUTF. Don't worry. Or able to eat 3 teaspoons from a pot within 3 minutes. If the patient can eat 1/3 of RUTF or 3 teaspoons, this patient has passed appetite test. اوكي، مهم في شنو الابيتايت تيست. لو رجعنا في السلايد الورا بتاعت فيها الكومبليكيشن، ميديكال كومبليكيشن يا شباب، نرجع. لو شفنا في الرايت سايد of the slide outpatient care bilateral beating edema grade 1 or grade 2 severe wasting بتعريفه الاثنين appetite test passed، يعني لازم يكون pass appetite test، يكون no medical complication as I say and child is well and alert. لو في الشروط دي this patient can be managed as outpatient. Okay, if there is severe wasting again and again, if there is severe wasting بتعريفه الاثنين سواء بالمواك ولا بالويت for حياة. Okay, or severe edema grade 3 with medical complication not passing appetite test and the patient is not well or not alert or any complication, this patient need hospital admission. I hope it is clear. Okay, in coming slide we are going to speak about inpatient care or for the patient of malnutrition. بعد ما عرفنا criteria for admission خلاص دخلناه المستشفى. Okay, what is inpatient care? We have what is called 10-step approach. Please this is very important. We have 10-step approach. عندنا حاجات بالريد، أي حاجة بالريد معناها very serious, starting from stabilization phase, then transition phase and rehabilitation phase. Okay, in stabilization phase you have to handle the first hypoglycemia, hypothermia and dehydration. Okay, لو شفنا الرسمة الثانية WHO 10 steps for treatment of SAM. عندنا 10 step approach. هنا عندنا stabilization phase وعندنا rehabilitation. usually في stabilization it lasts from بنقول 2 to 7. طيب في 2 to 7 days data مقسمينها لاثنين، عندنا first 1 and second day، وتاني عندنا from day 3 to day 7. We have 3 main complications, 3 main serious medical complication you have and you should handle within the first 2 days of admission. They are hypoglycemia, hypothermia and dehydration, and this is usually the causes of the death. يعني لو سألوك what are the causes of the deaths in malnutrition هم الثلاثة ديل: hypoglycemia, hypothermia and dehydration, because they are very very serious medical complication you have to handle in the first 2 days of admission. نحن لسه في الاستابلايزيشن، فضل لنا من day 3 لحد day 7. عندك بعض الحاجات هتعمل لها هاندلينج، ان الانفكشن اللي هي ستيب 5، الالكترولايتس ممكن تكون مستمره معك لحد الريهابيليتيشن ما في مشكله، لكن عندنا الانفكشن اللي هي ستيب 5 you have to handle in stabilization and you have to start cautious feeding again in stabilization, cautious feeding. Okay, regarding transition it will take 1 to 2 days، وبعدها بنخش في rehabilitation phase it takes 2 to 6 weeks. in rehabilitation phase عندك باقي الحاجات you have to handle electrolyte برضو ممكن تستمر معك لحد rehabilitation phase، والcatch up growth، يعني rehabilitation هي catching up growth period or sensory stimulation including emotional and social support and prepare for follow-up and discharge. Okay, في السلايد in the coming slides we are going to speak briefly in each step. Number 1 step is prevent and treat hypoglycemia. What is the definition of hypoglycemia? Is any blood glucose less than 3 millimole per liter or 54 milligram per deciliter. As we say, all severely malnourished children are at high risk of hypoglycemia. وعرفنا الأسباب شنو. It is important cause of death. As I say, what are the causes? 3 causes of death in malnutrition: hypoglycemia, hypothermia and dehydration. What are the signs of hypoglycemia? As usual, lethargy, convulsions, drowsiness and unconsciousness even. How we are going to prevent? By frequent feeding day and night. Night feeding is so important to prevent hypoglycemia. Regarding the treatment, how we are going to handle the patient of malnutrition when he develops malnutrition, it divided into two main points. Either the patient is conscious or the patient is unconscious. If the patient is conscious, please, there is no role for IV route at all. يعني العيان conscious ما في IV route خالص. هنديه orally NG tube nasogastric tube feeding. هنديه جلوكوز 10% 50 مل NG tube. Okay, orally. طيب. Then you have to start feeding with F75 straight away. What is F75? We are going to know it solely. هنشرحها بعد شوية. What is F75? You have to feed this patient 2 hourly. يعني في اليوم هنديه 12 وجبة في اليوم، كل ساعتين لازم ياخد وجبة. Use feed chart to find amount to give and feed every 2 to 3 hours, day and night. You have to start antibiotic. Please, whenever you deal with a patient of hypoglycemia, please suspect a severe infection. You have to give antibiotic. And you have to consider hypothermia. Hypoglycemia and hypothermia and severe infection, they are coexisting with each other. Okay. The second important point, when the child is unconscious, lethargy or convulsing, here you have to consider IV route. You have to ندي طوالي bolus of dextrose 10% 5 ml per kg IV because the patient is unconscious, lethargic or convulsing. Then follow it by once time يا شباب, once time bolus of 5 ml per kg of dextrose 10% followed by the same 50 ml of glucose 10% by NG tube, and then you have to start F75 solely and you have to start antibiotic. This is treatment of hypoglycemia briefly in malnutrition. Okay. Step 2 is hypothermia. Definition is auxiliary temperature less than 35 degrees centigrade or rectal temperature less than 35.5 degrees centigrade. This is the definition of hypothermia. How we are going to prevent? By frequent feeding, number 1. Secondly is by warm this child and keep this patient dry. Okay. Treatment by kangaroo method. Once the patient has developed hypothermia, please use kangaroo technique, skin to skin with the child and the mother, bare skin, and cover them with blanket. Close child well from head down with blanket and place under lamp. Not fluorescent يا شباب. Or hot water bottle for rewarming. يعني زمان كان بيملوا القوارير موية حارة ولا الجلافز موية حارة ويحطوها فيه. No, it is an obsolete. So أهم حاجة, feed the child, warm the child, keep this child dry. If develop hypothermia, use kangaroo technique skin to skin with his mother and cover them with blanket. No role for hot water bottle or for rewarming. You have again as hypoglycemia, you have to consider hypoglycemia and you have to consider severe infection. As I say, hypoglycemia, hypothermia, severe infection, they are coexisting. Step 3 is regarding dehydration. It is very important point يا جماعة. Dehydration in malnutrition, it differs completely from dehydration in well nutrition child. So, in well nutrition child, dehydration signs, as we know, it is sunken eyes, it is eager to drink, skin turgor went back slowly or very slowly, and the general condition either irritable or unconscious or lethargic. 4 حاجات زي ما نحن عارفينها هي signs of dehydration in well-nourished child, and by it we classify the patient either no dehydration or some dehydration or severe dehydration, equivalent to plan A, plan B, and plan C. This is in well-nourished child. هنا عندنا الكلام totally differ. هنا in malnutrition, these usual signs it is completely not reliable, because sunken eyes, it is a part of the condition. Skin tear, loss of skin elasticity it is a part of the condition. It is a part of the disease. It's part of science in the disease in malnutrition. And regarding the general condition, لو قلنا irritability هم أصلا irritable, أصلا apathetic. So general condition we cannot rely on it. And the fourth is ability to drink. Malnourished child usually have a very anorexia. These patients are very severe anorexic. So these four main signs of dehydration is not reliable in malnutrition. So dehydration signs are no more reliable in severe malnutrition. Dehydration tend to be overdiagnosed. يعني لو قلنا sunken eyes هنلقى sunken eyes وهنلقى السكين بينش went back very slowly. بعد ساعة لو جيت هتلقاها لسه ما رجعت. هتلقاهم irritable وapathetic وكده، وهتلقاهم cannot able to drink وكده. overdiagnosed. Okay, overdiagnosed. So طيب هنشخص كيف الديهيدريشن in malnutrition. reliable signs زي ما في الجدول ظاهر لكم في المحاضرة. dehydration عشان نقول this child with malnutrition is dehydrated بنعتمد mainly على history of profuse diarrhea. يعني لو الأم قالت لك there is history of diarrhea for 1 week, for 2 to 3 days, you have to consider dehydration in this condition. Then thirst, the patient is recently developed thirst and sunken appearance يا جماعة of recent onset. Please recent onset. طيب طوالا خدت لكم septic shock. You have to consider septic shock in such patient. Septic because this patient have subtle signs of sepsis. As we know, they are not able to develop signs of infection, signs of inflammation. زي ما فهمنا وعرفنا في reductive adaptation. So you have to consider septic shock if the patient is hypothermic or if the patient is limp or apathetic. You have to consider both dehydration and septic shock. If there is weak pulse, لأن البلس بنعتمد عليه yes, weak absent radial pulse, cold hand and feet, urine output is low, you have to consider both dehydration and septic shock. Please don't rely on mental state. زي ما عرفنا انه ممكن it will be affected by hypoglycemia, hypothermia and septic shock. Don't rely on dry mucous membrane and skin elasticity. طيب what is the treatment of dehydration? Please there is no role of IV route except in shock. So what are the treatment for dehydration? Is orally. Number 1, rehydrate orally. Use IV route if the patient is shocked. طيب what are the type of fluid? We use Resomal. What is called RESO MAL, MAL stand for RE اللي هي rehydration والSO solution والMAL of malnutrition. So بنختصر نقول Resomal stand for rehydration solution of malnutrition. It is characterized by less sodium, more potassium, plus magnesium, zinc and copper. This is Resomal. You have to know it very thoroughly. طيب هندي الامount. What is the dose for Resomal? زي ما عرفنا orally, route is orally, type of fluid is Resomal. Okay. The dose is 5 ml per kg every 30 minutes for 2 hours. 5 ml per kg of Resomal every half an hour for 2 hours. Then you have to measure pulse rate, respiration every 30 minutes for these 2 hours. Then after these 2 hours, you give 5 to 10 ml per kg per hour for next 5 to 10 hours in alternate with F75. Please stop hydration if the patient appear hydrated. What are the signs of hydration? إنه يكون passing urine, moist tongue, making saliva, no more thirst. دي الساينس اللي ممكن نعتمد عليها إنه البيشنت is hydrated. طيب أهم حاجة يا جماعة you have to stop this hydration if the patient develop increasing in respiratory rate and pulse rate or in good JVP اللي هو jugular venous pressure or increasing edema and puffy eyes لأنه بنخاف شديد إنه البيشنت يحصل له fluid overload. And as we know in when we are speaking in a reductive adaptation إنه these patients of malnutrition are have fluid overload فنحن منزيد لهم الفلويد overload. طيب so المونيتورينج حقنا respiratory rate والبلس rate والurine output والgeneral condition of the patient. Okay, last point regarding dehydration يا شباب you are not allowed to use standard ORS عندنا oral rehydration solution العادي ده. This is forbidden in malnutrition because it contains more sodium. So we use Rizomal, rehydration solution of malnutrition. Okay, شباب, regarding step 4, electrolyte imbalance, give extra potassium and extra magnesium because, as we say, in reductive adaptations, these patients have low potassium and low magnesium. Step 5, treat and prevent infection. As we know, all severe malnourished children are at risk for severe bacterial infection. Especially because these patients have subtle or absent signs. Assume presence of infection and you have to give broad-spectrum antibiotic since day one of admission. Step 6, correct micronutrient deficiency. Micronutrient, importantly, is the vitamin A deficiency. We have vitamin A deficiency signs in eyes. This is homework. Please go and read about signs of vitamin A deficiency in the eyes in malnutrition. Other micronutrients you have to give folic acid, zinc, multivitamin, and iron, but after transition phase because iron is increased free radical, as we know in reductive adaptation. Step 7 is start feeding cautiously. Nutrition treatment divided into 3 phases: initiation phase or stabilization phase, transition phase, and rehabilitation phases. طيب يا شباب, regarding step 7 is start feeding cautiously. In feeding treatment, nutritional treatment divided into 3 phases. Initiation phase, which is stabilization. Stabilization phase is so important. We mean by stabilization, you have to handle the 3 main causes of disease. As I say, hypoglycemia, hypothermia, infection, and dehydration. This is main causes of death. You have to handle in this stabilization phase. Then you have transition phase, usually taken 1 to 2 days, and lastly rehabilitation phase. قبل ما نمشي فيهم شوية بشرح, we have feeding formula F75, RUTF, and F100. يعني شنو الحاجات دي؟ F75 is starter formula. يعني شنو؟ يعني هي الفورمولا اللي بنبدأ بيها starter. يعني we use it in initiation phase, in stabilization phase, because it contains less energy, less protein. Why less? Because the patient is not stable for high energy and high protein. يعني انت في المرحلة دي انت عايز to save life for this patient. You are not targeting high energy, you are not targeting increase weight, you are not targeting high protein to increase the body mass or كده. So you are giving a low energy, low protein formula. This 75 number is stand for 75 kilocalorie. Regarding F100, again, this 100 is stand for 100 kilocalorie. It contains protein 2.5 gram. This is per 100 ml. Okay, F100 it contains more energy and more protein. It used in rehabilitation because it is water based. Lastly, we have RUTF. RUTF is lipid based. Okay, يعني هي حاجة شوية يعني جامدة شوية. F75 F100 is water based. RUTF is lipid base, is energy dense, mineral and vitamins rich, equivalent to F100 formula. It contains the same kilocalorie and protein it contains the same energy and protein as in F100. What is the difference between F100 and RUTF? That is, RUTF can be used in outpatient. Never use F100 in outpatient because it is water-based, which is more liable to contamination. So when we are discharging the patient, we give this patient RUTF. So in rehabilitation phase, we use F100, and when discharging, we give this patient RUTF. These 3 feeding formula provided freely by WHO. نرجع تاني initiation phase. What we are mean by initiation, as I say, stabilization. Please continue breastfeeding for this patient. The route of feeding in this stabilization is NG tube because the patient is anorexic, as I say. Night feeding is so important يا شباب to prevent the hypoglycemia. Please give feeding 2 hourly, each 2 hourly. يعني في اليوم هنديه 12 وجبة يا شباب. الفيدنج فورمولا بتاعتنا F75. Initiation phase usually end when appetite return to the normal. Regarding in transition phase, as I say, usually it take 1 to 2, maximum 3 days. We use F75 to RUTF, F100, no problems. Usually in initiation phase, appetite should be return normal, edema subside, and medical complication should be resolved. Regarding rehabilitation phase, it usually take weeks. It take weeks, 2 to 6 weeks. Here there is no role for F75 at all. Here your goal is not save life or your goal is not save life or dealing with any medical complication. Here your main target is increasing weight and rehabilitation for this child psychologically and emotionally. So RUTF or F100 used in rehabilitation, as I say, feeding freely, measuring and giving feeds please, recording on daily care chart. You have to involve the mother psychologically, emotionally. These pictures خدتها لكم في المحاضرة. The first from right to left is plump nut is RUTF. Secondly, it is اللبني ده is F100. الثاني orange ده is F75. This is all 3 formula are provided freely by WHO وavailable عندنا هنا في أحمد قاسم. Okay. Again, phase of treatment, stabilization, transition phase, and rehabilitation. For rehabilitation, rapid weight gain is your goal. Lastly, you have daily care during stabilization. You have to care about the skin because you have what is called dermatitis. You do daily bathing with potassium permanganate. Again, you have care of the eyes because this patient is liable for conjunctivitis. This patient might develop signs of vitamin A deficiency in the eyes. As I say, it is homework to read about signs of vitamin A deficiency in malnutrition. You have to deal with conjunctivitis. You give the patient tetracycline, chloramphenicol drops, atropine to relax the cornea in the malnutrition because corneal detachment and corneal dehydration, it is one of the signs of vitamin A deficiency. Please involving and train the mothers. These mothers are psychologically usually depressed. You have to speak with this mother. نوريها صور لعيانين قبل وبعد عشان تشجعها للادميشن لأنه usually ممكن ياخد معاك 1 week 2 weeks ممكن تزهق. Emotional support, psychological support. Use toys for the baby. Admitted mother is the only person يا جماعة to help this child. You cannot deal with the child alone without his mother. Lastly, we have discharge criteria. طيب يا شباب, lastly we have discharge criteria from inpatient. يبقى كلامنا كله كان على inpatient care for the child with malnutrition. children from 6 to 59 months referred to outpatient care if the following 3 important things are applicable. discharge if the patient أهم حاجة يا جماعة يكون well. يعني you can't discharge patient ill. You can't discharge patient ill or unwell. So the patient should be well, should be alert يا جماعة، مصحصح، واعي، نصيح، كويس، بقى معاك well. Okay, this is number 1. Number 2, MUAC MUAC more than 125 millimeter or 12.5 centimeter and no edema for at least 2 weeks. Third important point, wait for height of at least more than -2 standard deviation or more than -2 Z score and no edema for 2 weeks. This is the discharge criteria from hospital. Important يا شباب. Lastly, outpatient care unit management. عندنا حاجة اسمها outpatient care unit management CMAM community management of acute malnutrition. indication 200 يعني العيان ما حدخله المستشفى. قبل قلنا لو كانت الابيتايت تيست باست ومنه medical complication والchild is well and alert قلنا this is not indication for malnutrition، صح؟ في الحالة دي هنقوم نحول العيان ده لوين؟ ل community management of acute malnutrition اسمها CMAM. في الحالة دي هيتابع معاهم يمشي ويجيهم وياخد RUTF. indication bilateral bleeding edema as I said previously يا جماعة. في الأول قلنا grade 1 or grade 2 edema not grade 3 لأنه grade 3 with medical complication is indication for hospital admission. number 2 severe wasting alone without medical complication يعني severe wasting plus يكون الابيتايت test passed no medical complication child is well and alert. توفرت فيه كل الحاجات دي this patient is candidate for community management. community management يمشي يتابع مع العيادات المحولة لناس التغذية متوفرة في كل المراكز الصحية عندنا في السودان. هنا في أحمد قاسم عندنا، في علي عبد الفتاح عندنا، في كم مستشفيات، هنا في جعفر بن عوف كلها عندنا مستشفى، عندنا مراكز لسوء التغذية بنديهم RUTF free this community management of acute malnutrition.